So far. So we're going to go ahead and get started this afternoon. Welcome to everybody to today's Genomind Grand Rounds event. My name is Gabriella Williams. I'm one of the medical science liaisons here at Genomind, and will also be serving as the moderator for today's discussion. I'm very excited for our event today. We have an exceptional panel of clinicians here with us today that are going to be presenting and discussing some real-life patient cases of patients that they've worked with within their practices, and really using those cases to highlight their use of pharmacogenomics within their clinical practice, as well as the overall utility of pharmacogenomic information in medication management and patient care in general. Now, before we introduce our panelists and jump into these patient cases, just a couple of housekeeping items for everybody. First and foremost, to those of you joining us in the audience today, we cannot hear you or see you. You're currently off camera and muted. However, you do have a Q&A functionality at the bottom of your screen. So please feel free throughout the discussion today to drop in any questions that you might have for our panelists. And we'll answer those questions as we move along throughout today's presentation, and also answer any follow-up questions we might have at the end of the event too, as time permits. In addition to that, we always get questions about whether this presentation will be available in the future. This event is currently being recorded, and a recording will be uploaded to the Genomind Healthcare Provider Learning Center at genomind.com/360. And on that website, you will find not only a recording of today's presentation, but also a recording of past Grand Round presentations and webinars, as well as additional educational material that you might find helpful. So without further ado, it is my utmost pleasure today to start introductions of our panelists. And I'm actually going to have each provider go around and introduce themselves, as well as introduce their practice. So John, would you like to get us started?
Hi, thanks so much, Gabriella. Thank you, Alexis, and all those at Genomind for setting this up today. Dr. John Stevens, boarded in adult psychiatry, child and adolescent psychiatry, and obesity medicine. I am owner of a group practice here in Houston, Texas, called Psych Insight, as well as a co-owner of another practice for comprehensive assessments. We do in-depth individual assessments, as well as IOP services called Inner Space. Happy to be here.
Awesome. Thank you, John, so much for joining us. Michelle, how about you?
Nice to see you, Gabrielle. Thank you for having me. I'm Michele Novella. I'm a psychiatric nurse practitioner in Danbury, Connecticut. I'm the owner and medical director of Star Psychiatric Healthcare. Beside myself, there are 5 other psychiatric nurse practitioners and about 6 therapists, and we see children, adolescents, and adults. I've been using the Genomind testing. I think it's going on 12 years now since it first began, and it's been a huge asset to my practice. So I'm so happy to be here today to talk more about a case study.
Well, we are excited to have you. Thank you for taking your time this afternoon. And Steve, how about yourself? Steve, you are currently muted.
You're mute.
Sorry about that. Okay.
There we go.
Yeah. So Steve Salzbrenner, I work at Nebraska Medicine. I run the esketamine clinic there, work in the psych ER, lead the treatment-resistant depression clinic, and do some outpatient work. Been using, like Michelle, I've been using Genomind since it came out. I was an early adopter when people had no clue what I was doing. And they still sometimes don't have a clue what I'm doing, but I still use it. And I'm excited to be here. I did this once before, and I really like the format. I think it's a great environment to just discuss some of the challenging cases and learn a couple things. So thank you for inviting me, and I'm looking forward to it.
Of course. And again, thank you all so much for taking your time out of your busy schedules today. I think it's very clear to myself and probably to all of those joining us in the audience that we're in very good hands today. We've got years and years of pharmacogenomic experience amongst the 3 of you, and I think we're really going to have a robust and insightful discussion today. So why don't we go ahead and start diving a little bit deeper into our cases. John, do you want to get us started today?
Sure. I'm going to tell you about one of my earliest experiences with Genomind. I don't know if it's as early as Michelle, maybe 8 years, but definitely was it Genocept Assay 1.1 or some name like that. So, and I'll tell you how my use has changed. So this was an early patient. I'll put some slides up just so everyone could follow along. As you see, the chief complaint for this 52-year-old divorcing Caucasian woman, a mother of two, who worked in the Houston area as an executive director of a nonprofit. She came to me with a history of 2 failed trials of selective serotonin reuptake inhibitors, or SSRIs, that were prescribed by her primary care physician. And her chief complaint, as you see, was, I thought I could tough it out on my own. I can't figure out why. I don't even know why I'm anxious. Now I could barely function, intense crying, hopelessness, out of work right now. Mrs. B, again, worked a job that she described as high flying and hard driving. It was not uncommon for Mrs. B to work more than 50 hours a week. And she told me, of course, the why now, why did she come to the office, was that several weeks before our initial visit, she was at a conference where she was the featured speaker. And typically she had no difficulty speaking in front of large audiences. However, at the conference, at a preliminary session, she was seated when she began to experience symptoms that approximated a panic attack. When I asked what this meant, she talked about rapid heart rate, shortness of breath, clammy hands, and even embarrassing diarrhea. She was so embarrassed that she returned to her hotel room, where she said that she was, in her words, freaking out. Again, I asked her what this was, and she said similar symptoms that led her to become bedridden for the next 36 hours. She remembers crying inconsolably. I asked her about precipitating or aggravating factors, and she talked about chronic work stress, difficulties with her board. She talked about marital stresses and said, I was really strong throughout the separation. I thought it was finally over, but I carried a lot of guilt about what this is going to do to me and my children. She told me that her general practitioner had prescribed escitalopram, but this intervention had a terrible reaction, she said, a terrible adverse reaction, after only 1 or 2 doses of an introductory dose of 5 milligrams. The general practitioner switched her to fluoxetine, and again, a very low dose of 10 milligrams. And she could not tolerate this medicine for more than 1 to 2 doses because of what she described as increased anxiety, description of agitation, certainly insomnia, and more diarrhea. About the fluoxetine, she said, it was like I was receiving poison. And she had a very negative feeling about her general practitioner, with whom she had worked with for years because of this. Her description were so dramatic about these, what I thought, low dose SSRIs, only for a couple doses. My initial thought was, is this a histrionic reaction? Is this illness, anxiety, or somatic symptoms? Just because it seems so unusual. Moreover, less than 1 week prior to our initial evaluation, Mrs. B was seen in a local ER, where she received lorazepam for symptoms of what, again, she described as panic. In addition to the lorazepam, which she said made her feel calm, but also kind of loopy, she took routinely 25 milligrams of diphenhydramine or Benadryl at nights just to fall to sleep. She said she had some neurovegetative symptoms of depression, but in my estimation, not enough to meet criteria for major depressive disorder. She complained of non-purposeful weight loss of approximately 7 pounds in the last month, which she said was due to uncommonly low appetite. She described periods of psychomotor agitation, which did seem worsened by the SSRI therapy. She denied suicidal thinking, but recalled during the episode that I described earlier of panic at the conference, like she was fainting, even though she was fully awake. In our additional session, we agreed to a trial of low-dose sertraline therapy, beginning at 25 milligrams, again, cautious. However, in just a few days, Mrs. B called me to report the emergence of similar adverse effects to what I described before. She said she was agitated, she couldn't sleep, she felt jittery all the time, and complained of trembling of the hands. At that point, again, this new technology, Genomind's Genocept, at that point, one of the early versions, she came to the office for a buccal swab for this test. Again, mental status, I'm not going to go through that part of this. Was clearly a very high achieving, well-educated woman. She was not looking up, she was not Google docking this, she just was asking and complaining of symptoms. And again, despite some of these complaints, came in fashionably dressed, not appearing intoxicated or withdrawing from any substances, not suicidal or homicidal, no symptoms of psychosis, no history of hypomania or mania, no family history of bipolar disorder. Her medications were medicines primarily for hypertension. She was on amlodipine, hydrochlorothiazide, a water pill, levothyroxine for some hypothyroidism, and a potassium supplement, likely related to the hydrochlorothiazide. The Genomine results, as you see, I'm not going to go through all of the findings, but again, back then, unlike the 24 or so genes that are tested now, there was perhaps a half a dozen, included some pertinent findings. Specifically, she had high risk of non-response with being SS at the serotonin transporter, or the SLC6A4. Notably, she had low activity at CYP2D6. These were relevant because these two findings suggested low chances of response and an increased rate of side effects with traditional SSRIs, especially in Caucasian individuals, which Mrs. B was. So my decision, in retrospect, of using the sertraline was probably not the best one, and I quickly changed course, explained to her why we had to change course, and while those other two trials of escitalopram, fluoxetine were likely also to be have low chance of being successful and a higher risk of side effects, and we needed to go in a completely different direction. Due to the complaints of insomnia, her weight loss, and the really strong anxiety component, which was increasingly looking like generalized anxiety disorder with panic attacks, we agreed to start mirtazapine therapy. Again, a relatively common introductory dose of 15 milligrams. I could have gone lower, but I chose an introductory dose because I felt that this would be, giving her standard treatments would be helpful. Again, she did not like the feeling of lorazepam, and we decided to discontinue that. I did give her the PRN use of propranolol, a centrally acting beta blocker, at 20 milligrams twice daily. In our fourth session, this is approximately 1 month after her third session, Mrs. B's symptoms were largely contained, I'm happy to say, or in early remission. She decided to take a sabbatical from her nonprofit and was looking into possible career changes. She said that she realized she enjoyed time off and was spending more time with her children. She had followed some of the recommendations I had given about behavioral activation, and not to just be lying in bed for prolonged periods of time, that to try to get out, wake up at the same time every day, become more physically active could be helpful, and indeed it was. So much so that in her next session, 2 months later, her symptoms were largely in remission. Her blood pressure was interestingly better controlled. She was happy to report that she was receiving numerous job offers for different positions, which she said she found more exciting and enticing. She denied any interval panic attacks. She had been off benzodiazepine successfully for several months, and actually, because of some of the costs of my practice, actually requested to go back to her GP, who accepted her insurance. I gave her enough refills to do that. She checked back in several months later, told me she continued to do well, follow up almost quarterly at this point. Her visits had really stretched out, but was continuing on the medicine, and she was doing well. Next slide, if you wouldn't mind, Gabriella. So again, my reaction to this, what I was trying to highlight for the group is, I ordered pharmacogenetic testing for a patient with unusually poor responses to various SSRIs, both in other providers' hands and then with the sertraline in my hand. Ultimately, this patient responded very well to PGX-guided treatment. That's what we call it, PGX-guided, for this with an atypical antidepressant called mirtazapine. Admittedly, there were psychological factors at play. Clearly, this patient was a high-performing perfectionistic individual who was once cited as Houstonian of the Year in her respective profession. However, life stressors, change of life with marriage, and needing a new life direction, I think, was also important changes that she had to make to really turn the page on a previous aspect of her life. I would say prior to pharmacogenetic testing, I probably would have prescribed her another antidepressant, perhaps referred her to more insight-oriented psychotherapies for what looked like somatization or psychological exaggeration of side effects. But honestly, after seeing these results, it was pretty obvious that we were going in the wrong direction, unwittingly. And the information was very helpful for the patient and this prescriber. Over the years of using this, maybe not as long as Steve and Michelle, I've broadened the application of how I use the test. As you could see in this early version, I used it for a patient who didn't respond to usual doses or had a really unusual response. I've since broadened the use of PGX for patients that are on multiple mental health medications. I really like using Genomind's GenMed Pro, where I could put in multiple medications and really have big data computer kind of check those drug-drug interactions. It's very common for me, for pediatric patients or even adult patients to call and say, my general practitioner, my dermatologist, my OBGYN started this new medicine. Is it safe to use with my current regimen? The true answer, I don't know. But using some of the computer programs we have, we could check it out and I could give them an informed response. I also use, as we did for Mrs. B, use PGX testing for patients experiencing significant medication-related side effects. I now use it for patients even worried about potential medication side effects, the Google Doc kind of situation, or the situation of someone saying, well, I heard my best friend tried this medicine and had all these horrible side effects. To give someone peace of mind, getting the testing ahead of time, or patients new to care, especially young patients, it gives parents peace of mind before we start the medicine, that the medicine will be compatible with an individual's pharmacogenetic or pharmacodynamic gene variations, their own biochemistry. So I hope that case gets us kicked off. It was probably a relatively simple case compared to what we've seen now later in career. This patient wasn't on that many medicines, had a relatively easy to control condition once we found the right medicine, but ultimately a very good outcome. Thanks, everyone.
Thank you.
Thank you so much, John. I think that was such a good example of how pharmacogenetic information can really help us reprioritize the way we think about moving forward with the patient and use that information in the context of our treatment algorithms, because our treatment algorithms are very broad, they're very vast. First, second line, you're still looking at 10, 15 plus medications that we could be choosing from. So it's really helping us reprioritize or rethink through those options. So let me ask Michelle, Steve, any insights or any questions regarding that case?
I think you did a great job presenting it. You're so organized. I give you credit for that. I think you made an excellent point at the end, right? It doesn't need to be when there's a case that is completely mind-boggling. Of course, it's super useful in those times, but I completely agree. I don't do a lot of children and adolescents, but one of my partners does, and I strongly encourage her, especially when she has a young child or an adolescent who's been naive to medication. If they don't need to start the medication instantly that day, how efficacious it might be, and how reassuring to parents if we start off right foot and without the the sort of guesswork that we do. I think that's a really important market. And I agree. It doesn't have to be a difficult case, but for sure, when you see somebody coming with polypharmacy from the previous provider, or as soon as I hear, oh, I've been on 2 or 3 SSRIs, I already kind of know what I'm going to see on the report, but I'm sure that there's more information I can glean and get the patient engaged with me to going forward.
Yeah, that was really good, John.
Thanks.
I was wondering, so 2C19 must not have been on that early panel, because they had that S-citalopram reaction, and I thought, oh, for sure they're a poor metabolizer at 2C19, but maybe it wasn't on that early one. I don't know.
Yeah, 2C19 and 2D6 were actually two of the originals, so yeah, that probably was on there. The newer ones were 1A2, 2C9, and I think 2B6.
Okay, gotcha. 2B6 is good because of the esketamine that I do.
Yeah.
And Wellbutrin. So yeah, I just would second everything Michelle said, John. That was just a really good case of a practical application of technology, and good for you. That was good. Thank you.
And very validating, if I didn't point it out, from the patient's perspective, helpful for me, helps me look good, those results and using those results. So kind of, from the provider perspective there, but from Mrs. B's perspective, that she wasn't quote unquote crazy, and that her unusual response, and this is how she would talk about it, to the medicine she already felt so much pressure, again, with her board, the marriage failing. There was a lot of shame. And while we don't usually consider failing a medicine shameful, in her mindset, she took it as that. It was just another thing that wasn't working well for her. And, her GP telling her, like, this should be fine. What's going on? Even myself, I had some wondering in the back of my mind early on, as I kind of told, for her to see it on paper, and this is why it will work. There's the patient education, but then it was validating for her. And when Michele was talking, I realized to maybe emphasize that if I told the story again from the patient perspective, which is like, okay, it's not me, okay, or blame it on your parents, the genetics you inherited.
It's so true. I can't agree more. I cannot agree more on that. It's such an important buy-in, because even if the provider who prescribed those earlier meds didn't necessarily say, wow, I really can't believe that happened, there's a subtle, because it's a questioning mind. Wow, 5 milligrams of Lexapro to have that strong an effect.
Yeah.
It makes us question that. And even if we don't, outright say it to the patient, they get that sense, because of course the patients have always a desire to please the provider, right? To sort of come back and be like, wow, this was great, because we are excited when that happens.
Yeah,
So they
what a miracle.
So John, let me ask a quick question here, and I'll open this up to the panel as well. You mentioned at the end of this case that Miss B ended up going back to her primary care physician for further medication management. So this is often a discussion that comes up, and even barriers that other practitioners face, of how do we make sure that this pharmacogenomic information is being conversed or is being sent over to other providers? And how do we make sure that other providers are aware that this information can be helpful in the decisions they may make moving forward? Is there anything that you guys do to ensure that in your practices?
To ensure that it's helpful?
To ensure that other providers are aware of the information or aware of the test results, for example.
Gotcha.
Mm-hmm.
I think very briefly, for me, I'll make sure that it's sent along to the other providers, but I make sure my patients are so facile with the information on the results that if they wanted to look up a medication and find out what the pharmacogenetics were, they know how to do it, right? I tell them, this is how you would look up Tylenol, right? You go to the Google box and you put in, acetaminophen pharmacogenetics. And hopefully if you find a Wikipedia article, you might be able to see how Tylenol is metabolized, because they're so happy to have that information and have the utility of it. Because I can't trust that all the other providers out there understand it, even in this day and age.
Yeah, and I've memorized it. I think it's section 12 of the FDA package insert, and that's sad that I've done. Anyway, I agree, Michele, like a lot of the providers are still kind of confused by the technology. It's intimidating, I think. And I'm not a geneticist. I don't know what a lot of these things mean. I don't know the nomenclature. That's always changing. So the way the report is designed is really for people like us to understand. And I really like, I've seen several of the different companies' reports, and Genomind, I think, has the most user-friendly report. I personally like that best. But I will not hesitate to talk to the providers, invite them to come discuss results with me, because I'm kind of now seen as the guy who sort of gets it in the office. And I'm happy to do that, because I've seen too many patients benefit from the results and the kind of evidence-based treatment decisions.
It's a good place to be in, Steve, being the expert in this.
Well, it can be scary too.
Yeah, I agree with Steve, and he mentioned it earlier that still some people don't understand or misinterpret it, don't know where to put the value on the tests, or confused by the different tests that are out there and different claims. Some people cannot differentiate what I call recreational kind of testing, whether it's like Ancestry or 23andMe from Genomind, which is a clinical product. I think that's where some of the education comes in. And, I think healthcare just moves so quickly. People just want the answers. So for this case, just saying that, and if providers are more curious, I could go into depth, but usually it's kind of saying, listen, this is why it didn't go well. This is the medicine. And I honestly suspect that for this patient, she's no longer on medicine at all. She needed it temporarily for a phase of her life and difficulty, but can do well without it. giving them that high level information, Gabriella, in my experience, is probably what's most helpful for very busy frontline providers.
Perfect. Wonderful. Well, thank you all for those insights. Just in an effort to make sure that we get through all the other cases and stay on track here, Michele, I'm actually going to toss it over to you if you want to talk through your patient case. I'll let you actually introduce it, and then I'll pull up the report as well as we talk through the genetics.
Great, thanks so much.
Mhm.
So my case is, and I'll try to have you guys just imagine in your mind's eye because I don't have slides, a 28-year-old single white male. He works as a manager of a mid-size airport in the tri-state area. Decent high-level job. He goes to grad school part-time. He's getting his MBA. He was referred to me by his therapist for about, who he'd been seeing for about 2 or 3 months. Been with a different prescriber. I'll go straight to the diagnoses and then we'll work back from there. The diagnoses that I came up with and that had sort of matched what he had had were major depressive disorder, recurrent severe, no psychosis, ADHD, predominantly inattentive type, and obsessive compulsive disorder with both compulsions and some obsessions. Really super nice guy, single. One of his complaints was that he had not been dating pretty much ever and had never been sexually active and very much identified as heterosexual and wanting to be in a relationship, but had such overwhelming anxiety, could not get to that point of even thinking about dating. The compulsive components of his OCD were his zest and zeal for exercise. He would run 5 to 7 miles every single day, 7 days a week. If he didn't get one of his runs in, his anxiety symptoms would escalate. He'd be very uncomfortable and agitated. He also avoided a lot of situations where he might have to talk to strangers or interact with somebody in doing small talk is what he called it. And he had said when he was in grade school, he had been identified as having inattentive type ADHD, which was pretty surprising because he was 28. And usually most of the time, as you guys all know, a lot of times you don't see those people identified that early on, especially if they're not hyperactive, right? The typical picture in our mind's eye of a student who gets diagnosed is usually the one who's behaviorally out of control, pinching the kid next to them. He just was looking out the window frequently and very intelligent guy. So when he came to me, he had been on Lexapro 20 milligrams and Wellbutrin 300. He did say that many years back, maybe at the end of high school, he had his primary care provide something and he couldn't remember what it was. But he definitely did not feel as though medications were helping him significantly. The doctor had previously put him to Wellbutrin XL 300, and he definitely noted that made him very agitated. So probably wasn't the best for him. And the longer his symptoms went untreated, the more significant his depression got. He had pretty much a traumatic childhood, no history of trauma, no history of abuse, just the diagnosis of ADHD, positive family history for anxiety disorders and also for ADHD. Never been in the hospital for depressive symptoms or for suicidal ideation, no self-harm, no substance use whatsoever. I think he said once in a while he would drink occasionally, which is a lot of times frequent with people who are super anxious, worried about potentially getting the deleterious effects and not being in their right mind, the way Dr. Stevens said his patient didn't like the way she felt on Ativan. Super common complaint. And he'd also been on, in the past, Vyvanse, a lot of GI symptoms. He said he wouldn't remember to eat. And he was sort of a thin guy to begin with. So that was a problem for him. And he did notice significant calming down symptoms when the medication wore off. So I did my best, and I put him on initially Paxil CR and escalating doses up to 50 milligrams, which is pretty, robust, if that's the word. He noticed some benefit to his anxiety, but he also noticed that he was gaining weight, which was not acceptable to him. He was very fit into running. He gained about 25 pounds very quickly. He also noticed, even though he wasn't sexually active, that he was not functioning sexually. And to that, I mean, I think he was having problems with even, masturbation. And of course, any 20-year-old who has that problem, it's significant, right? a lot of GI discomfort, a lot of GERD, mild irritable bowel syndrome kind of stuff, but not to the level where it would necessitate actual treatment. But, you know, waxing and waning issues with his gut, especially when he was anxious. So, and like I said, a low mood, you know, I do this kind of self-rating scale for the patients. It just helps me. I'll say, if you had to put a number on your mood, where 0 is the saddest and the worst you've ever felt, and 10 is the happiest you can recall ever feeling, what number would you put on your mood today, right? And for him in the beginning, it was like, you know, a 2 or a 3, maybe on a good day for him, it was a 4. Not very good. I usually tell people that the goal is where most days your mood will be a 6, 7, on a great day an 8, and maybe on a not a great day as low as a 4, but not much lower. And it seems to be consistent over time that that's what a lot of patients get towards. So after the Paxil, I tried Prozac. Of course, I look back now and say, why did I do that? Because that was a 3rd SSRI. I should have known better. I probably shouldn't have done that. But, you know, we're not always on our AA game. I was on my maybe B+ game. And I thought maybe the Prozac will speak to his OCD symptoms. But sure enough, same issues, didn't work. And at this point, this important phenomenon occurred. The patient was losing trust and losing hope that we were going to find a medication that was going to be efficacious. And that's a super dangerous place to be, right? I could see he was a good guy, so he was still coming to his visits, but I could just see that he was starting to question, you know, whether or not this was actually going to be worth his while. And his therapist was sort of getting anxious that we got to a better place. I discussed the test itself. Of course, you know, it takes some salesmanship because it's not a free test. And I told him it would be some out of pocket to him. You know, it would be not 0, but it wouldn't be thousands for sure. It would be something that he could afford. And he quickly jumped on board. He was definitely like a left brain, liked information. And in retrospect, I was so happy that I did it for this patient in particular, just because when I knew the results would speak to him specifically. So I'll start out, you can put up his report if you want to, Gabriella. Let's see if we can zoom in. I wonder if you can do that. So of course, the first variation that I assumed that he did have, right? The serotonin transporter gene variation, where the SSRIs were not likely to do very well with him. And that had been borne out. I told him, you know, for the future, if you stop seeing me, make sure you never probably let somebody put you back on an SSRI. And I will say this to the Genomind people. Do you remember back when that result included a piece about having a lower stress response or a more likelihood to have increased stressors because of the amygdala? I hope you guys maybe remember that. But I loved when that was on there, and we can speak to that later. So he understood that he was validated as to why the SSIs were not working well for him. He also had the MTHFR polymorphism, which is such an easy fix. I have my own, and I'll just show it quickly. After all these years, I've made my own algorithm or diagram about how folic acid is circulating in your system from your diet and how the MTHFR enzyme is deficient, depending on if it's heterozygous or homozygous T. So for this gentleman, he had one parent who passed down the variation known as T. And the way I explain that to the patients is I'll say, the genetic test shows that you make approximately 25 to 40% less of the MTHFR enzyme than somebody who doesn't have this genetic quirk. And I'll always, you know, use a really kind of cute euphemism for them to remember MTHFR. You know, I'll say it stands for methylene tetrahydrofolate reductase, but you'll remember it as the mother gene, right? And they'll remember it that way. And so helping them understand that L-methylfolate is actually, whoops, wrong way, my finger, is actually the building block that is allowed to cross the blood-brain barrier and is the substrate that helps to make more serotonin, dopamine, norepinephrine, and also melatonin. And if they don't have enough of the enzyme to get a lot of L-methylfolate, then they're not making optimal amounts of those neurotransmitters. And I guarantee you, every single patient you have knows what serotonin, dopamine, norepinephrine is. They all perk up when you say that, as well as melatonin. So, and I remind them that the medications we prescribe don't do anything in terms of producing those neurotransmitters. They work with whatever you have endogenously at that point in time. So, because as you guys know, frequently when you prescribe, let's say, a supplement for a patient, they understand immediately, but ask them again in 6 months why they're taking it or why they stopped taking it. It's because they forgot why they needed it in the first place. So I make sure every patient goes home with the diagram. And I also add that L-methylfolate is the substrate to help make glutathione, which helps clear toxins from their body, potentially lowering inflammation, and that seems to get them excited as well. And I send them home with a diagram. Okay. And he also had a variation in his BDNF test, and he was heterozygous. One of the genes, one of his parents passed down the MET allele. So we know how important BDNF is in terms of its role in synaptogenesis and neuroplasticity. And the good news for this gentleman was he was fascinated by this, which is great. I love when a patient is super interested in something, and so am I as well. So I was explaining to him how wonderful it was that he was exercising, and how cardio definitely helps to produce more BDNF. And in fact, people who have the variation on that gene seem to have a compensatory mechanism where their bodies make even more BDNF when they have exercise efforts than somebody without that genetic quirk. So I encouraged him to continue to exercise, but we sort of came to a point where we decided 4 or 5 days of running would be more appropriate, and stretching and yoga might be more appropriate for 3 or 4 days. And I gave him a couple of articles to say that, you know, this was new information about yoga and stretching, because I don't think we knew quite as much about how that played a role in increasing BDNF. He loved it. I did a podcast on that too, on BDNF, and I sent it to him, and he thought it was terrific. Let's see what else. We can see that he had the, just very briefly, the one that said that he probably would need more opiates because he had a less than typical response to normal doses of opiates. And he said, oh my God, that's exactly what happened. I had an ACL repair maybe about 6 or 7 years ago, and I was in agonizing pain because they were giving me maybe 1 Percocet every 4 hours. And it took at least 3 days for them to realize that that was not working. And so we made I made him promise that he would, you know, copy that result and literally keep it in his wallet along with the serotonin, along with the pharmacogenetic results. So in case he ever went to the hospital or if he was having surgery, he could whip that out and show the anesthesiologist as well as his post-op doctors, because you can't really tell, you know, your providers, oh, I have this really weird quirky gene where I need more opiates than somebody else, because most of the providers will be like, oh, sure you do, okay, right? It always helps to have some proof in that regard. And again, validated his experience tremendously. His pharmacokinetic variants were poor CYP, where was his, let's see, poor CYP, where, oh, here we go, sorry about that. CYP 1A2, and also, or he was at least an induction sensitive, and he didn't smoke pot and he didn't really drink a lot of coffee, nor did he smoke, so it wasn't too much of an issue. And the CYP2C9, he was an intermediate metabolizer, and ABCB1, right? So a lot of issues with gastro side effects, which for him certainly played a role. So we switched his medications. We did an abracadabra. We went away from the SSRIs and we went to the SNRI category, right? Because my choices were either or SNRI or tricyclics. So we put him on Effexor. I was so excited at this point because everybody knows if you don't have a very compliant medication patient with Effexor, you're going to have an unhappy patient because the half-life is so short. If you miss a day, you feel miserable. So if somebody is sort of a sloppy pill taker, you probably don't want to put them on Effexor. But his zeal and excitement for what we were about to do definitely carried through, and he understood to take it every day. We got him to a dose of 225 milligrams. It definitely helped him. He noticed a significant decrease. He still had some avoidant issues, but the level of obsessive thoughts and the rumination clearly, he said, if I make an effort to sort of address that my worry thoughts are going round and round, they have a more likelihood of breaking up and disappearing, which was so helpful for him. His mood improved significantly, but not enough to remission, right? I always remember the Stephen Stahl, tenets in his psychopharm book saying, we don't want just a response. We should be aiming for remission, which is an absence of symptoms. And it raises the bar for us for sure. So he was in agreement, and we added a little bit of augmentation medication, which in his case was Rexulti. Typically, the doses of that are 2 to 3 milligrams, according to their PI. I found that just 0.5 milligrams seemed to just give him that little extra push and improve his mood even more so, and also addressed his anxiety very well. He, of course, went on L-methylfolate, 15 milligrams, was so excited to get it. And if for all you guys who need to know this, it used to need a prescription, but now you can buy it on Amazon, and the prices are significantly better. This price was often a complaint for a lot of patients, and the fact that their insurance typically don't cover it. Trazodone was great for his nighttime sleep issues. He had anxious people, depression, all of them. Difficulty falling asleep, middle of the night awakenings, early morning awakenings, which, as you guys also know, is super common with people who are depressed specifically. I don't usually see early morning awakenings in other sects or cohorts of patients. It's almost pathognomic for depression when I hear it. And that was great. That worked out. He just needed 50 milligrams every night. And we just tried a new ADHD medication because of the ADRA2A information. I said we might as well try a methylphenidate group. This, as I believe it, this result doesn't mean that the amphetamine group wouldn't work. It just means that the studies, and you guys will correct me if I'm wrong, seem more robust when it comes to the methylphenidate group. So he was all for sticking to what the test said might be helpful. And we put him on Focalin CR 30 milligrams. It seemed to work well. He was still able to eat. It's not the most appetite suppressing ADHD med. It didn't overstimulate him, and it actually helped to lower his anxiety, which we also see a lot when we have somebody with concomitant anxiety and ADHD. I'm sure you guys will speak to this. When you add a stimulant, when you would usually think that that would make them overstimulated or anxious, being able to focus on one thing at a time and not have 15 different things running through their head at once seems to lower their anxiety level, which has been a really nice finding for me over the years. Let's see, did I cover all his medications? Yes, Effexor, Rexulti. I think actually he's been doing so great. Oh, he joined a dating app. This is super important. As you can imagine, somebody with social anxiety, a history of not being the best in the dating and relationship department. To date, he's been on at least 10 dates. I kept telling him, when you've gone on 10 dates, I'm going to give you a gold star. I can't wait. He's been on over 10 dates because I said, it's all about, it's a matter of throwing against the wall. It's a numbers game, right? The more, the better. And he actually has had 2 3-month-long relationships, and he did very well. And when they ended, he didn't end them, the girls ended them. He actually tolerated it pretty well. He was able to really articulate, the good parts about it, the bad parts about it. And he was starting to formulate what the important things he was looking for in a partner. Really came a long way. And especially for somebody who's in their 20s, it's super important because we know that their levels of wanting to, or taking their medications inconsistently happens a lot, right? They'll come to our office and they'll be like, well, I didn't really tell you, but I sort of stopped taking XYZ, right? So the beauty of the test for this gentleman was having him buy back into his treatment, right? He loved the information. He was the kind of person that was going to go do more research on his own, and I encouraged him to. He understood why he had needed to exercise his whole life. It was probably, in one aspect, a way of medicating himself in a healthy way. He didn't know what BDNF was, but it was clearly helping him. So
I think that is actually so important to highlight in your case, is just how engaged your patient was. I think that's really what stood out to me in this, great use of the pharmacogenomics in terms of prioritizing medications moving forward. But I absolutely loved how engaged you were with the patient and making sure that the patient felt comfortable and confident in that information. And actually, if we have time at the end of the presentation, I'm going to come back around because I do have a question about that, but I want to make sure that Steve gets a chance in the spotlight as well to discuss his case. So we'll circle back around to any questions here in just a second, but Steve, I'm going to toss it over to you.
All right, I'm unmuted now. Well, thank you very much. I'm going to present mine. This is a guy I've treated for a long time. Maybe started about 6 or 7 years ago. Well, I consider it a long time in his case, maybe 8 years ago. He's a 26-year-old male who is a nurse, a psychiatric nurse actually, and has a bachelor's in nursing. He has since then gotten his like a doctorate in some kind of psychopharm. It's like an advanced psychopharm degree in nursing, and I don't know the exact name of it, but it's competitive. And he's got the master psychopharmacology NEI certificate, so that's kind of hard to get to. In the Neuroscience Education Institute, it's the Stephen Stahl thing, and it takes a lot of work to get that. So he's very knowledgeable, I guess is my point, on meds. Single guy, history of bipolar 1 disorder, and just kind of was never really fully stable. I was always kind of on the cusp, kind of didn't sleep well, couldn't relax, had been hospitalized once at that point for mania, and then while I was seeing him a second time for mania and hallucinations, actually auditory and visual hallucinations. And I was kind of frustrated because, well, he was a nurse and he didn't like this. He'd been through, I'll give you a little list of all the meds. So I'm looking at my old notes from previous practices I've been in. So Saffris, Geodon, Seroquel, lithium, most SSRIs, Viagra, mirtazapine. At that time, Brintellix, now Trintellix, vortioxetine, topiramate, modafinil, doxepin, buspirone, aripiprazole, lamotrigine, lorazepam. I mean, everything. And of course, he's frustrated, especially a guy that knows his meds. He was gaining a bunch of weight, always tired. And I was like, the heck do we do now? I don't know. Very frustrated. So luckily I had already kind of been doing the testing, so I didn't really wait. I sort of said, let's just get this now, because with your history, why just add one more random med? Why throw one more dart at the board? Let's just get the results. So do you mind pulling, do you have his results to pull up, Gabrielle? If not, I can maybe just say what.
Give me one quick
Okay.
second and I'll get them pulled up. If you want to keep talking, I'll pull them up.
Yeah, sure. So what can I say about him? Anxiety was another thing that he struggled with. A lot of anxiety that was uncontrolled. So the first thing, when I looked at this, the first thing I noticed, because I don't know why I'm so obsessed with MTHFR, but for whatever reason, I guess I've seen a couple people have miraculous. Not everyone responds to L-methylfolate. It's not like a miracle drug, but when they do, it's pretty cool to see. So I noticed the MTHFR right away, and he's a compound heterozygote, which is pretty significant. Their production of MTHFR is really, really low. So especially, I don't know if you see down there the COMT, he's a Valmet, which is normal. But if you have an MTHFR problem and you're a val of COMT, it's like you can't make the dopamine and you break it down too fast when it's there. So I always look for that. Like for me, that's like gold, because then I can just give them like some Wellbutrin, some L-methylfolate, and like send them on their way, and they like think I'm God. But this person, this guy, yeah, we put on the L-methylfolate and he did fine, but he was still really tired, wasn't getting a whole lot better, really tired, and the moods were still fluctuating. So I decided, after hearing some Steven Stahl stuff, I decided, well, you're on the Abilify, which I've seen cause weight gain, although not commonly, but when it does, it can cause a lot of it. And I've seen it cause sedation, again, not common, but let's just get a level, because you've been on so many different meds and I don't feel comfortable just changing to another one. Let's figure out what's happening internally. So we got a level of his aripiprazole. And if you look down at the cytochromes, there wasn't like a really compelling reason to get the level according to these pharmacogenetics. So Abilify is like a 3A4, and I believe some 2D6, mostly 3A4, I believe. So I thought one of those was going to be poor, but it wasn't. But I thought, let's get it anyway. And anyway, and I don't know why this happened, but the aripiprazole level was like double what it was supposed to be, and he was on a 30 milligram dose. I still maybe the glycoprotein, maybe it was increasingly absorbed. Maybe Dr. Dowd can help with that. I still can't figure out why the aripiprazole was so high, but it was. And so we started to take that down, and it really, really helped with his weight, and it really helped with his sedation. But then, of course, now we're without a mood stabilizer. What do we do? So I decided, let's try this again. Let's get a Lamotrigine level, which Lamotrigine levels are common in neurology because there's a therapeutic level for seizure control, but in psychiatry, we don't really use those levels. So I'll sometimes get it if there's been a poor response, just to see how the body's metabolizing it and get a general idea. Anyway, it wasn't until we got up to 600 milligrams a day that he finally even entered into the like neurologic therapeutic window. And amazingly, once we got him on his final, so you remember that whole list of meds, his final list of meds included bupropion 450, Lamotrigine 600. He was on pregabalin. That's the only thing that helped his anxiety, which I've seen it very good for anxiety, and it ended up working. And then the L-methylfolate, not even a single antipsychotic. So those 4 meds, and he's been stable since that time. He joined Orange Theory and lost tons of weight. Now he does Go Low because he likes that better. He's doing fantastic. Now I wanted to mention to everyone, so lamotrigine inhibits folic acid metabolism. So if someone's got an MTHFR polymorphism that causes decreased production, and they're on lamotrigine, I think it's really important to give them at least the 15 milligrams, maybe even more, of the L-methylfolate. So in his case, I'm glad he's on the L-methylfolate, but I wouldn't hesitate to go even higher if there was ever a reason to suspect that, like if got macrocytic or something, I thought something's up with this folic acid. But that's it. So we went from I don't know, like 30 meds down to 4, and no antipsychotics and no weight gain, sleeping well, and ended up marrying one of the other nurses he worked with on the psych unit. So that was interesting. He's doing well. So that's my case.
So just a comment from my standpoint listening into that, I think your case was such a good example of how the pharmacogenomic information can be used in the context of other information, like these laboratory results that you are getting to further monitor what's going on with these different medications.
Right.
And using that conglomeration of information to make our decisions on what the next step is going to look like for this patient.
Yeah, and I also want to bring up that sometimes there's a pertinent negative too. You might have like a normal pharmacogenetic result, and that's not unhelpful. And it tells you there must be something else happening here, so then hence the levels. I'm curious about both Dr. Krause and Dr. Dowd's thoughts on the P-glycoprotein and how much that can affect the levels of something like aripiprazole. I would be curious on that. And then really the MTHFR, the importance of that, because that might have been what tied all this together. And it gets a bad rap. Sometimes people think that it's I don't know, emphasized and overvalued, but when it works really well. And I tell patients it's not a miracle, but if it works, you're going to like it. And if it doesn't, then don't stop it, because it's not going to hurt you. And if they get pregnant, you know, a prenatal vitamin is not going to help you if you have an MTHFR problem. So for women of childbearing age, I think it's important to consider pharmacogenetic testing just for that reason alone.
Mm-hmm.
And just for the people out there, you might want to add why that is. Why is that, Stephen? So like,
I didn't expect an exam. Yeah. So like neural tube defects, like you can have some significant birth defects if you, especially if you're on something like, well, you should never be on Depakote when you're pregnant, but if you are, Lamotrigine is pretty relatively safe. But in general, to prevent those neural tube defects, some folic acid supplementation is recommended. But folic acid supplementation is not going to be much good unless you got normal MTHFR.
That's right. And they actually do make a prenatal that has, instead of folic acid, has L-methylfolate, Nevo DHA. And it's funny when I do teenagers, you know, when their parents are in the room, I'll say, "This is your daughter won't remember this. You need to remember, Mom." You know,
and Michelle, have you ever noticed that some of those are covered by insurance? Like sometimes there's a little loophole where if they're pregnant, they can get insurance to cover the L-methylfolate.
Okay.
If you give it like as Embrace or as what you just said.
Okay, Nevo DHA.
And Steve, really quick, just to comment on that ABCB1G and the P-glycoprotein efflux pump. So the difficult thing with that gene is that it doesn't always consistently change your serum levels, because that P-glycoprotein and the variation we can see because of ABCB1 can not just affect intestinal absorption, but blood-brain barrier penetration as well. So you may be seeing changes not only in serum levels, you may actually be seeing the brain level changes as well. So sometimes that one can be a little bit more difficult to quantify in terms of levels, but we definitely have seen evidence in studies where we can see patients be more sensitive to medications and an increased risk of side effects when we see that variation too, which does make me wonder, could that have been one of the factors happening there with the aripiprazole?
Yeah, I wish I would know. It's been like haunting me for years. Like, why does the Abilify level get so high? I don't know. I found some evidence he might have been on Aristata. This one might have given us some Aristata, maybe the two combined. I don't know.
All right, guys, so we just have a couple of minutes here left today. So I actually wanted to go to some audience Q&A. There's a really great question in here that I'd like you guys to comment on. One of our participants asked, have you ever come across any cases where the phenotype or the genotype shows that a medication might have a higher likelihood of working for a patient, or that the patient might tolerate that medication better, and that hasn't been what's panned out in clinical practice? How have you approached that, and how have you explained that to your patients?
I definitely think that happened, for sure, right? That's happened. This is a lot of times what's on paper doesn't necessarily show, because there's so many different factors, number one, that we don't know about yet. Right? There might be another gene SNP that we haven't discovered yet that might show that on the one hand, it looks like it might be a good medication, but down the road, we'll find out, oh, it's not because of XYZ. You know, it's not a perfected test. It's not a guaranteed test. I guess I don't have a better explanation than that, but it has happened for sure.
And to look at what other things are going on. If medicine is, predicted to have a higher chance of working, a low risk of side effects, like Michelle kind of said before, the medicines don't work if they stay in the pill bottle. If someone has, poor adherence, if they're mixing with alcohol or other substances, you have to really, it starts off another conversation about lifestyle, or what are you doing in addition to the medicine, psychotherapy, lifestyle changes, the kind of, to me, it's a conversation starter. It's not like, oh, well, the test didn't work, now what? You talk about levels, therapeutic plasma levels. I think that's great and underutilized for a lot of medications.
Yeah.
So I'm so glad Steve brought that up as well. So it's just, you have to keep looking under every rock and kind of starting those conversations with patients.
And on the converse, sometimes a med will work. I guess Michelle kind of alluded to this, even though maybe they're an SS of the serotonin transporter and Prozac's the only thing that works. I mean, pharmacogenetics is a tool of one of many, many tools, and no one should ever rely on pharmacogenetic testing as their one prescribing guide. It's just in the toolbox, and that's what I tell people.
Mm-hmm. And I think that's definitely, here at Genomind, we talk about these golden rules of pharmacogenomic testing, and that is one of those key principles, that this is meant to be a piece of the puzzle, and it's probabilistic in nature, not deterministic. And we need to be sure we have those conversations and set those expectations with our patients for sure. Well, everyone, unfortunately, we have come up on our time here today, but I think this has been such a wonderful discussion and a really wonderful highlight of different patient cases in different contexts and different practices that has really highlighted the way that you all use pharmacogenomics and how helpful that information can be in the care of your patients. Just as a reminder to everybody who has joined us in the audience today, a recording of today's event will be available on our Genomind 360 learning platform here shortly after today's presentation. And we do hope that we'll see everyone again for future Grand Rounds presentations and events. And I hope everyone has a wonderful rest of their day today. Have a great one, everyone. Bye-bye.
Thank you for inviting us.